Very good evening, ladies and gentlemen, fellow pulmonologists, physicians, doctors with special interest in pulmonary medicine who have logged in today. Today, we are going to discuss something with respect to something that has been, let's say, common for a very long period of time, decades or even centuries. We are having a panel discussion to discover the perfect cough syrup combination. My name is Atri Gangopadhyay. I am the East Zone Governor of Chest Council of India based at Ranchi, Jharkhand. And basically, I am giving a small introduction of a topic which shall be followed by a wonderful panel discussion which we have planned for you. Cough syrups. It is a saga of belief and confidence building. It is something that is a legacy from generation to generation. We remember our grandparents telling us that they trust so and so cough syrup, our parents telling us they trust so and so cough syrup, and same for us, not only as patients, but also as practitioners. Cough is the most common presenting complaint and irrespective of system involved, and it can be really distressing. Sharing some real life scenarios. Any kid going to school coughing will be sent back home in nowadays. I can think it's a cough. Parents can say it's just a cough. The doctor will say it's just a cough. But someone Google it and find that it's a terrible disease. So cough can actually be a harbinger of some terrible disease also. And since COVID era, whenever you hear someone cough, we feel really, really scared. That's why cough is something even more important when we are trying to live in the post-COVID era. Symptomatic relief is very important because there can be injury from cough. A patient can have syncope, fall down, injure himself or herself. Multiple severe bouts of coughing can cause rib trauma and even rib fractures. And lots of hernias are attributed to cough. And patients who undergo hernia repair are specifically told to control their cough. What may be the devastation from untreated cough? Jobs. It can affect your job even to the point of losing a job. Social isolation. You can't fit into a social gathering. Sleep. Many people tell me that I cough so much at night that neither I am able to sleep nor my family members are able to sleep. Eating. Patients can have difficulty in eating comfortably due to bouts of cough, and sometimes, unfortunately, it can result in choking also. Cough syrups are one of the oldest remedies. Highest number of permutation combination of any class of medicine. Certain controversies with respect to cough syrup. Many thoughts persist that it is just a placebo and no medicinal use. There are debates regarding the alcohol content in cough syrup. Certain cough syrup have been classified as banned drug or medicines with abuse potential and may not be available even when medically indicated. Certain combinations in the cough syrup have been in the wrong sort of news as harmful combinations causing damage and sometimes, unfortunately, fatalities. And there is controversy regarding dosing of cough syrup. Is it 1 teaspoonful? Is it 5 ml? Or sometimes it is the whole bottle. So there are certain controversies with respect to cough syrup. What may be the possible indications? Mucolytic and expectoration, cough suppression, or certain miscellaneous indications. So let's come to the panel for today evening. It's a multi-specialty panel to have multi-dimensional coverage of the delicate but precious topic of cough syrup. Dr. Vibhu Kawatra is a pediatrician and a pulmonologist from New Delhi. Dr. A.K. Srivastav is a pharmacologist and a pulmonologist from Rourkela, Odisha. Dr. M Manimaran is a pulmonologist from Chennai. Dr. P. Arjun is a pulmonologist from Trivandrum. And Dr. Sachet Dawar is a pulmonologist from Noida. Our panel today consists of pediatrician, pharmacologist, and the three pulmonologists. One of them is a private hospital, one of them is at a private DNB teaching institute, and one of them is at a medical college. So we have people here who encounter cough syrup at various levels, various strata, and for various populations. And as per the motto of CCI, we have people from the various zones of the country. So now, before we move into the very exciting discussion today, I would want to invite Dr. Vibhu Kawatra next, who will talk about a little bit about his experience with respect to adult and pediatric pulmonology and cough syrup.
Thank you, Dr. Atri, for a wonderful presentation. So now I'm going to have a very short talk on the cough syrups in pediatrics. So first thing we need to understand is that the FDA does not recommend any OTC medicine for cough and cold symptoms in children younger than 2 because they could cause serious and potentially life-threatening side effects. Normally in US, the manufacturers voluntarily label these cough and cold products to state that do not use in children below 4 years of age, while the American Academy of Pediatrics recommend avoiding their use in children less than 6 years of age. In India too, the guidelines are very clear. No cough and cold syrups are to be used below 6 years of age. So legally speaking, you should not be using these cold and cough medicines below 6. The another thing is that according to the American Academy of Allergy, Asthma and Immunology, coughing helps a child to remove the mucus infections and irritants from the respiratory tract. So as we all know, it's basically a protective reflex which is there. So there is a little evidence that the cough medicines really work better than the home remedies in easing a child's cough. But despite the fact that it gets resolved on its own over a couple of weeks, cough medicines do not clear cough, but it can help in alleviating the symptoms, and the child can feel more comfortable. So it's just a kind of a remedy which is given for a short period of time so that the symptoms can be alleviated. Although below 6, it's not recommended. Now, what are the usual causes of cough in children apart from those which are already there in case of adults? GERD is a very, very important cause of cough in children. Especially if you see what happens about 6 months of age onwards, we find the GERD quite frequent in children, and they have a reflux condition which responds very well to products like ranitidine. So they respond very well, and that remains till about 2 years of age. Beyond 2, there is a persistent, but then in that case we change to PPIs and all for a decent period of time. One thing is another which is to understand is that in case of small children, we say that normally the child should be fed and be burped. Now the purpose of burping is this, that the GRD can actually result in a small amount of aspiration, and that can actually result in coughing. So GRD is a very, very important symptoms in the infants as well as in case of the young children. Pollution is again another thing which is there. It's basically an irritant. So pollution basically can cause the symptoms, and there is an increase in the number of patients during the cold season, and especially during the farm fires and all which is there in the northern India more frequently we see. So during that period of time, the coughing can increase. Allergies is another cause. Then foreign body. Now this is again very important. Suppose you get a history of a very short duration of cough which is there, whether the parents just present that the child suddenly started coughing, then remember foreign body could be one of the major reasons for this cough in children. Then fumes from the automobiles and all. Exercise induced cough is seen in case of the teenagers and all usually, and it can be basically associated with asthma or without asthma. That depends on the condition. Then bronchiolitis. Now this is one condition which probably in October onwards we'll find a lot of cases, especially in the northern part of India. Now this bronchiolitis issues mostly occur in children less than 2 years of age. So this is again one of the causes of cough in case of children. Then pneumonias, whooping cough, which is there, and then as I already mentioned that apart from already the common causes which are there in case of adults. So in case of children, we have to think about these additional causes apart from what are there in case of the adults. Now, what works best in children? Just remember one thing: most of these children are going to get all right without medication in 2 weeks. So the best thing is just a supportive care. So what are the home remedies? We have to give a lot of fluids because fluids work best. Just remember that the nose is flowing, they're having a lot of cough, the sputum is being produced, so they need fluids. So that fluid works very well. Then menthol rubs. Again, menthol rubs help in the soothing of the chest and all in case of the younger children. Humidifiers are being used, and it's usually the cold humidifiers and not the hot ones which are used in case of the younger children. The reason for not using the hot ones is because there's a chances of burning which is there. Honey again works as an excellent soothing agent in case of the cough in case of very small children. Now, one thing is to remember: do not give honey to children less than 12 months of age because the chances of infant botulinum increases. Saline nose drops and sprays work wonderfully well in case of children, and they help in clearing of the secretions which are in the upper respiratory tract. Now, the sprays which are to be used, just remember, normally in case of children, we use the normal saline sprays, and we do not prefer to use the hypertonic saline in case of the young children unless it is absolutely indicated. Then streamy showers is there. Again, it helps in clearing of the airways. And nasal aspirators. Now, nasal aspirators are easily available in the market as well as you can get it online. They are very small bulb-like thing, which is something like a blood pressure bulb, where you just put it in the nose. Give it a pressure, put it in the nose, and then just leave it, and it can actually help in removal of the aspirations which are there in the nose and in the upper part. Then apart from that, propping up your child helps works wonderfully in helping for getting over with the cough, especially in case of the GRD. If you see in case of young children, it happened with my own children. What used to happen, we used to burp them also, and despite that they used to cough at times. So we used to put them on a small recliner kind of chair, and put it for nearly about an hour or so, and it helps in preventing the cough in the later stages. So, and the sore throat that comes with cough, you can give suckling on a popsicle that can help relieve the scratchy throat. But just remember one thing: it is only with the older children you can give the popsicle. If you're going to give it in the younger child, the chances of getting aspirated is pretty high. It can get stuck in some of the airway, and it can create more trouble for you. So thank you very much. It was a very short talk, and I think we can just go on for the discussion. Over to you, Dr. Atri.
Thank you, Dr. Vibhu. This reminded me like when first 15 overs of one-day cricket and Virendra Sehwag and Gautam Gambhir used to bat that make the maximum runs in those first 15 overs and India wins the match. So you told us maximum possible thing in minimum possible time, and I'm sure everyone who heard your discourse will be very, very comfortable, if not treating pediatric patient, at least being doctor treating their children for various type of cough with or without cough syrup. So now we come to our panel discussion, and with the question answer. Obviously, children first. I would start with our pediatrician, Dr. Vibhu. In various pediatric prescription, why there is tendency to always give at least one cough syrup? You want to agree, disagree? If yes, why? If no, why not?
So let's be very clear. So as I already said that as per the Indian guidelines too, you're not supposed to give cough syrups to children less than 6 years of age. That's being very clear. Now that's about science. But at the end of the day, remember one thing: we are humans too. So just remember, if your child is crying, your child is uncomfortable, what's going to happen? You're going to panic a lot. So you want to give a kind of a cough syrup to every child, and that so that the child can peacefully sleep. The normally the kind of the patients which I get, and the parents come कि बच्चा पूरी रात सो नहीं पाया डॉक्टर साहब बिल्कुल the child has been very uncomfortable. Remember, if the child is going to be uncomfortable, most of the parents nowadays are working parents who are coming at least to the private. So what happens if the child is uncomfortable, the parents are uncomfortable. If the parents are uncomfortable, they'll make your life uncomfortable. So as a pediatrician, normally every pediatrician prefers give a cough syrup that alleviates the symptoms to a certain extent. That won't cure, but that's definitely going to bog down the symptoms, and the child is going to sleep well. The child sleeps well, the parents sleep well, the parents sleep well, the pediatrician sleep well. So probably that is the main reason which every pediatrician prefers to give a cough syrup. And another thing is, in Indians, it's a tendency. So maybe we might be having a discussion on the cough tablets and all which are there, the lozenges, and there are a lot of things which come for the adults. They come for the children. It's not there, but it's a tendency. It's a mindset in Indians that you need to give something which is in the liquid form. You need to give that khansi ka sharbat to get the proper cure, or at least in the minds of the parents. That's the main thing.
Your comments raise two very important possibilities in my mind. First, 10 or 15 years ago, growing up kids actually had lots of caregiver. Either one parent was at home or work schedules were no taxing, so other parent could also come home. There were some grandparents to take care, some unmarried uncle, aunt, and elder cousins. But nowadays, it may be sick child at home, both parents working, no siblings, no other relatives. So that is something
Absolutely.
very big.
Absolutely, and,
Secondly,
and 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 the biggest thing is with what we have seen is like even nowadays, even the government is recommending that you need to have those crutches and all in school. So normally, they're trying to put everybody in that kind of a place where the child has to be kind of independent, and you need your child to be quick, and you have your own commitments. So everything is, I would say, the pressures are too high, and we are actually paying for our single families and the nuclear families. That's we don't understand, but we are actually paying heavily, and that's going to reflect on our children too.
secondly, a common belief is there, which again you highlighted, that syrup is something wonderful for cough, as if it will directly go into the airways and bring out the cough. So basically, we need to make our patients understand that there are two tubes, and normally oral ingested substance do not cross into that other tubes. If it crosses into that other tube, it's a strict no. So maybe something like that, parent education or patient education should be there, that the syrup or the sharbat is not going into that other tube.
Dr. Atri, you won't believe, but the kind of parents which I get. So at times, what happens, the child. So normally with adults, it's a different thing where you have cough and only cough. With children, what happens? You have cough, you have diarrhea too. So and in case you give an antibiotic, suppose the parent has taken an antibiotic, or it's a viral cough. Once the virus breaks down, then there is a bit of diarrhea. You won't believe, you'll get parents who will say कि डॉक्टर साहब अब तो कफ जो है वो लेटरिन से पिघल पिघल कर निकल रही है. So you get that kind of a thing, that concepts are there. And I listen to that every day night and day out. So it's there, and probably now. So after about 12 years of practice, now even I have accepted that ठीक है यार वहीं से निकल रही है. If you are happy, it's okay.
So another point highlighted that when we were studying, it was medical science, but when we are practicing, it becomes a medical art. So when we are talking about a medical art, our next question is basically, he's also an artist. I recently came to know that other than being a very successful pharmacologist and clinician, he is also a poet in Hindi, Dr. A.K. Srivastav. So basically, question to you, what are the different drugs used in cough syrup? Could you just enumerate or classify them?
Thank you, Dr. Atri, for such a nice introduction. And good evening, everyone. And thank you, CCI and Dr. Atri, especially for inviting me and giving me opportunity to speak on the platform of CCI. If I classify or enumerate the different drugs that are used in cough syrup, we have antitussives. Number one are antitussives. What are antitussives? That reduce the or suppress the frequency or intensity of cough. And antitussives may be divided into three groups. Like first one is centrally acting, second one is peripherally acting, and third one is central as well as peripherally acting. So what are centrally acting antitussives? Which suppress the cough center in the brain and increases the threshold for cough. So under the centrally acting antitussives, we have opioids and non-opioids. So in opioids, we have codeine, folcodeine, and ethylmorphine. And under non-opioids, those are basically synthetic substances or semi-synthetic derivatives of opioids also. So they are dextromethorphan, noscapine, pipagethate, and clofidinone. So these are the centrally acting antitussives. Now I come to peripherally acting ones. Peripherally acting antitussives, they basically reduce the tussle impulses arising from the pharynx, larynx, and lungs. So some of them are prenoxdiazine. Prenoxdiazine is a molecule which inhibits the pulmonary stretch receptors. The other group is demulcents. What are demulcents? They provide a protective coating over the sensory receptors on the pharynx, like honey, licorice, syrup tolu, and syrup osaka, etc. And the third one, which acts peripherally, is local anesthetics, which reduce the sensitivity of sensory receptors in the pharynx and larynx, like lignocaine and bupivacaine. And the third group, which lies under the antitussives, apart from centrally and peripherally acting, are those which act by both the ways, centrally as well as peripherally acting. So under this category, we have benzonatate, levodropropygein, and levocloperazine. So these were the antitussive drugs. Now I come to the mucokinetic drugs, or expectorant, what you call mucokinetics. What are mucokinetics? Which stimulate the flow of the respiratory tract secretion. So we have essential volatile oils like oil eucalyptus or oil anise. Second is ammonium chloride. Third is sodium citrate or potassium iodide, the salt of the citrate. Fourth one is guaiacol, and the fifth one is guanefenicin. Guaifenicin, that is the derivative of guaiacol, that is glyceryl guaiacolate. And the third group, after the antitussives and the expectorant, we have mucolytics. Mucolytics are the drugs which liquefy and break down the mucus. So we have the molecules like acetylcysteine, carbocysteine, bromhexine, ambroxol, and dornase alpha. So these were the three groups. Basically, you can consider as purely drugs which are used in cough syrups. So we have another groups of drugs which can be, I basically consider them as a supportive actors, like adjuvant drugs to be used in cough syrups. So we have four different another groups like antihistamines, that are H1 antagonists. So we have levocetirizine, diphenhydramine, bilastine, ibastine, chlorpheniramine, and diphenhydramine. The next one is bronchodilators. Bronchodilators, we have beta-2 agonists like terbutaline, salbutamol, or levosalbutamol. The third one is, or if we flow in a sequence, so fourth, fifth, sixth one is decongestant. So we have alpha agonists like phenylephrine and pseudoephedrine. And the last one is leukotriene antagonist, which is Montekulast. So basically, I personally consider them as the supportive actors apart from antitussives and expectorant plus mucolytics. So I have tried to classify the whole drugs, group of drugs into these categories. Over to
Thank
you,
you,
Dr.
Dr.
Atri.
Abhishek. I think that was very, very exhaustive. Means up till today evening, for my practice, I knew only suppressant and expectorant. But now you made it crystal clear for everyone here who are listening to practice better. From Dr. Abhishek, we shall move on to one of the fastest growing cities in India, Noida. And Dr. Saab tells that every week when he journeys to his college, he sees a new building standing over there. Dr. Sachet Dawar is working at Noida. A question to you. Which group cough syrups are highest prescribed globally, and also which combination or pharmacological molecule?
So first of all, I would like to thank CCI and yourself for inviting me as a panelist to this esteemed discussion. And although many buildings are coming up, but yes, super tech towers were also blasted off that day in Noida. So jokes apart, the cough syrups are a $5 billion industry globally, and the highest prescribed cough syrups are actually cough suppressants. They are in fact 5 times more prescribed than the cough expectorants. And out of these cough suppressants, dextromethorphan is one molecule that is maximally sold throughout the world. It's a non-opioid suppressant, as Abhishek sir has told, and it is freely available as the over-the-counter drug. And also, since cough usually comes with cold, so a combination of cough and cold medicines, which includes antihistamines like chlorpheniramine maleate and diphenhydramine, are used, and also some decongestants like pseudoephedrine are also used in combination with dextromethorphan.
Thank you, Dr. Sachet. From east and north of India, now we shall move a little bit south. We have from Trivandrum. He works at one of the largest private hospitals in India, and the DNB teaching program over there boasts about the highest pass percentage in pulmonary medicine. Dr. P. Arjun sir, kindly classify the cough suppressant, including or earmarking which are the opioid, non-opioid, or central peripheral ones, please.
Thank you, Dr. Atri. Let me at the outset thank CCI and yourself for having me in for one of your programs yet again. It's always a pleasure to be associated with the CCI programs because they're all very, very informative. Now, the question to me is, how do you classify cough suppressants? My job has been made quite easy by Dr. Abhishek, who has very clearly elucidated the classification. But since this is a very important topic, especially from the PG point of view as well, I will just go through it once more to reiterate the importance of that. So when we talk of cough suppressants, these are drugs that will suppress the cough. And cough suppressants basically are classified into 3 groups: centrally acting cough suppressants, which act at the cough center in the medulla. We have peripheral acting cough suppressants, which act on the stretch receptors in the lungs. And then you have a group of drugs which act both centrally as well as peripherally. Centrally acting cough suppressants are basically classified into 3 groups. Number 1 are the opioid cough suppressants, the classical example being codeine. You have non-opioid central cough suppressants, and the typical example is dextromethorphan. And then you have antihistamines like chlorpheniramine maleate and diphenhydramine, which can also be considered to be central cough suppressants. When we talk about peripheral cough suppressants, the most common ones are the local emulsions, which act locally, and as Dr. Abhishek said, they produce a soothing effect. They cover that inflamed area. That is one thing. And then you have lidocaine and bupivacaine, local anesthetics, which can also be used to treat cough. In fact, there are many cases of intractable cough, which we do bronchoscopy and instill lidocaine to reduce the cough. And then there are people who say that even steam inhalation can be considered to be an example of a local cough suppressant, which acts peripherally. Then you have drugs which act both centrally as well as peripherally, and the typical example is benzonatic. So this is in short how we classify cough suppressants as central, peripheral, and those which act in both areas. Over to you.
Thank you, Dr. Arjun sir. From there, we shall move again south, one of the oldest heritage cities of India, a balance between heritage, culture, development, IT, Chennai. Dr. Manimaran works at MIOT, a legendary hospital in Chennai. And the question for you is, while we are using cough suppressant, kindly tell us regarding the drug interactions to watch out for and other adverse effects arising from cough suppressant.
Thank you, Atri, for kind introduction. I'd like to thank CCI for giving this opportunity. Yes, Abhishek and explained, the two different types of cough suppressants, central and peripheral. Since these cough suppressants should not be used for chronic cough or with those who have accompanying excessive secretion, it's only short course, but usually be more beneficial in patients with acute cough or interacting cough or those with chest injury or those things. Since the centrally acting agents usually acts on the CNS, these things will produce much of side effects like blurred vision, dizziness, and those things. Peripherally acting are well tolerated and more effective too. The usual old opioid agents like morphine, codeine, all these things usually interact with all neuroleptic agents and antidepressant, those things. So also the side effects like urinary retention, especially in patients with benign prostatic hypertrophy and those with hepatic impairment, it should be used cautiously. And among peripheral agents, especially the levofloxacin or levodopa, all these things are local anesthetic agents. These are all non-narcotic agents. Usually works by numbing the pulmonary receptors. These are minimal side effects like dizziness and usually local side effects like tingling or some sensation or numbness in the mouth and the chest, and minimal side effects like headache and those things can be. These should be cautiously used in patients already on anticonvulsants and anti-anxiety agents, and also those on opioids. And among demulcents are a bit useful drug because it has soothing effect on the pharynx. It doesn't have much of systemic side effects since it can have a little bit of numbness on the oral area. So otherwise, these peripheral agents are well tolerated and very effective in comparing central cough suppressants.
Thank you, Dr. Manimaran. I have a confession to make. When I was an MBBS student, I was very afraid of pharmacology. And anyone they asked me regarding adverse effect, I used to say nausea, vomiting, and hypersensitivity. All other thing I never remembered. But nowadays, it's true. Patients first thing they ask us whenever we prescribe anything, that what are the adverse effects. So if you hated pharmacology as a student, you are forced to love pharmacology if you want to practice responsibly. Over to the next round of question. I would want to ask Dr. A.K. Srivastav sir, there is a confusion or overlap between mucokinetic, mucolytic, expectorant. Kindly explain difference between mucolytic and expectorant cough syrup with examples, if any.
Okay, basically, cough, the expectorant are basically mucokinetic agents. The mucokinetic agents are the drugs which stimulate the flow of respiratory tract secretions either by stimulating the bronchial cells to increase the volume and by stimulating the ciliary movement to facilitate their removal by coughing. So basically it increases the respiratory tract secretions and also facilitate its removal. So these are called expectorant or mucokinetics. So they are moving the mucus out. Whereas mucolytics are the drugs which alter the chemical characteristics of mucus to decrease its viscosity and to facilitate its removal by ciliary action or coughing. Many scholars they consider both of them as expectorants, so confusion arises here only. But I should say that mucokinetics should be considered as expectorants, whereas mucokinetics should be considered as expectorants, whereas mucolytics should be uh, differentiated from this group. So I will make you understand by giving some examples that first I will give examples of mucokinetics. Like I have mentioned in my classification that mucokinetics or expectorants are like essential oil. So essential oil, how they work, they basically stimulate the bronchial cells, secretory cells directly. Or ammonium chloride, if you take example, it is a gastric irritant which reflexly enhances the bronchial secretions. So mucokinetics also works through a different mechanism, like they have a reflex irritant effect on gastric mucosa, which is believed to initiate the reflex secretions of respiratory tract fluid. The ammonium chloride is the typical example of this. Another example, like sodium and potassium citrate, they increase the bronchial secretion by their salt action. And after absorption, the citrate gets converted into bicarbonate and the mucus becomes less viscid in alkaline pH. So this is facilitated by the mucociliary action of the mucosa. And lastly, the guaifenesin, after absorption, it is secreted through bronchial glands to increase airway and mucosal ciliary activity. So basically, these expectorants or mucokinetic agents work by increasing the secretion as well as facilitating the clearance of mucus through mucociliary action. Whereas if you take example of mucokinetics, so we have drugs like acetylcysteine. How it works? Acetylcysteine basically cleaves or it splits the disulfide bonds of the mucoprotein, which is a component of mucus, and thus liquefy the mucus because it has a sulfahydryl group, so it can split the disulfide bond of the mucoproteins. Another example is carbocysteine. It acts similarly to that. And the next example is bromhexine. Bromhexine basically depolymerizes the mucopolysaccharide component of the mucus. So one is mucoprotein, which is cleaved by acetylcysteine, and one is mucopolysaccharide, which is depolymerized by bromhexine. And bromhexine also increases the lysosomal enzyme activity to break the fiber network of tenacious sputum. Ambroxol, if we take example, is just a derivative of bromhexine. It is a metabolite of bromhexine, and it has similar mechanism of action, but it is more useful when mucus plugs are present. And lastly, we have Dornase alpha. Dornase alpha is the mucolytic, which is a highly purified solution of recombinant human DNase, deoxyribonuclease, which hydrolyzes the accumulated DNA in the sputum. See, basically in the patients of cystic fibrosis, there is high amounts of extracellular DNA released by degeneration of the neutrophils in response to infection. So Dornase alpha, how it acts, it hydrolyzes the DNA present in the sputum, and thus, so altogether mucolytics acts by lysing the mucus and liquefying it, and expectorants or mucokinetics make them move outside through coughing. So this is the
Thank you,
difference.
Dr. Abhishek. Very clear. For Dr. Vibhu, we have an audience question from Dr. N.H. Krishna sir, our CCI founder. Firstly, he's telling that he is very happy to see Dr. Vibhu hale and hearty and jovial after a very long time. And he is requesting you to tell about paracetamol containing antihistaminic cough syrup in pediatrics.
So, the first of all, sir, let's be very clear that it has no logic. Let's be very clear that it has no logic when it comes down to logics. But the fact of the matter is that whenever we have colds, whenever we have the upper respiratory infections, we have a lot of body aches. Now, remember, a child is not going to come to you and say, "Ki mere ko body ache ho raha hai," or he's having headaches or whatever. He's going to just get cranky. So to get over with that crankiness, the paracetamol is there in the cough syrup. So that it is a kind of like a cocktail. Make the baby or the child sleep, as well as give paracetamol, so there is no body ache, the child is sleeping well, and as I said, the parents are also sleeping well. So that's the only thing which is there. So it is just to keep the low grade fever under check, as well as the body aches under check. That is there. And to be very honest, yes, as pediatrician, uh, all pediatricians say it has no logic, but I think most of the pediatricians use it.
Okay. And to continue on that, whenever we are talking about antihistaminic, would you want to comment a little about bilastine syrup with respect to antihistamine in pediatrics, Dr. Vibhu?
Yes, so as far as the bilastine is concerned, so bilastine was has been approved by the drug controller below above 6 years of age in India. That's the first thing. Although we have studies above 2 years of age, but the fact of the matter is that we have the other molecule, which is cetirizine, which is easily available. The levocetirizine, which is easily available. And as I said, Dr. Atri, let's be very clear. As far as the kids are concerned, as far as the pediatrics is concerned, most of these kids don't really require those antihistamines or these syrups. So with bilastine, it failed miserably in this country because of two reasons. One is that the dose was supposed to be 10 milligram, which was there in 4 ml. Now, none of the cups which are there with the measuring cups which are there with the syrups have a 4 ml marking. They have a 5 ml or a 2.5 ml or 7.5 ml marking. So that's the first reason why it failed. The second major reason was it does not cause sedation. Now, if it's not going to cause any sedation, the purpose of giving the cough syrup is defeated. The child is not going to sleep. The child is not going to sleep. Then how would the parents relax? I mean, you're actually losing the purpose of giving the cough syrup. So that's basically the major reason why it failed miserably in our country.
Okay, thank you. Dr. Sachet,
Yes, sir.
going on to Dr. Krishna sir's question, he's very excited to see you today because we believe this is your first CCI webinar. So
Yes,
Dr.
sir.
Krishna wanted to see you. So he's requesting you to comment same paracetamol containing antihistaminic cough syrup, its role in adults, and also kindly explain some scenarios with cough where a cough syrup may not be necessary.
So as Vibhu sir has said that it is quite logicless to combine paracetamol with antihistaminics. But as we all know that our most of the people want a Ramban ilaj for the cold and cough remedies and like that. So they just want to consume one syrup and everything should be okay with that. And there are quite a few scenarios where you actually do not require cough syrups. So I'll enumerate a few of them. First is GERD, that is the gastroesophageal reflux disease. In this, you actually do not need a cough syrup. In fact, you need antacids, the proton pump inhibitors, and prokinetic drugs like levosulpiride. So also some general measures such as avoiding spicy food and having a light dinner and keeping your head end a bit high while lying down helps a lot. Another scenario is the cough variant asthma. Again, it is a type of asthma, so you do not need cough syrup in this. In fact, you need bronchodilators and the inhaled corticosteroids, and you get a very good response for the cough. And cough is the only symptom that the patient presents with in cough variant asthma. So they have already consulted many doctors, taken a lot of cough syrups, but it does not work. And next scenario is the post-nasal drip, or it is also called as upper airway cough syndrome. In this, usually the upper airway pathologies like sinusitis, post-nasal drip, etc. are there. And you need to adequately treat the causative pathology. So for sinusitis, you need to give appropriate antibiotics. And for post-nasal drip, you need to give appropriate nasal decongestant. And even nasal corticosteroid sprays help in this. So nasal decongestion like pseudoephedrine can help in this. So another scenario is our congestive heart failure. So in congestive heart failure, basically it can cause peribronchial coughing and edema. So that induces cough through the stretch receptors. And this is also known as cardiac asthma. In this, rather than the cough syrups, I think diuretics can help us better. And if a patient is taking ACE inhibitors, so ACE inhibitors have a common side effect, that is they induce cough. So you can replace the ACE inhibitors with 82 inhibitors, or you can just stop the ACE inhibitors for some times and ask the patient for review consultation with the cardiologist. And also, last but not the least, our one scenario is obstructive sleep apnea. Many patients with OSA complain of cough at night time, and so cough syrups will definitely not help in this scenario as well. What you need exactly is a CPAP therapy. So these are certain scenarios, and also some scenarios like vocal cord dysfunctions. In this also, patient will complain of cough, but you have to tell them how to deal with the secretions and the respiratory hygiene. You do not give them cough syrups as such. So these are few scenarios where cough syrups don't work.
Yeah, Dr. Vibhu, like an umpire, you show
Yeah,
the out
no,
symbol. Yes,
no. So,
please.
so what I wanted was, when I was listening to Dr. Sachet, so you're talking of paracetamol containing cough syrups in adults, and I think more or less you find the tablets which contain paracetamol along with the cough syrup combination. The beauty of these tablets, if you just compare it with the pediatric syrups which you see, you'll find the adults have caffeine while the pediatrics don't have caffeine. So probably I don't know about the adults how effective these tablets are, but what I know is that that itself proves that the caffeine missing from the child's cough syrup means you want the baby to sleep or the child to sleep. That is
Yes, sir.
one thing probably,
Okay.
because otherwise if you
Good
give
point.
caffeine,
Good point.
the child is going to just wake up. So you're going to defeat the purpose.
Okay. One good point raised by Dr. Sachet is, which everyone here should note, including the audience, that whenever there is an unaccountable cough, kindly think of sleep apnea, sleep disorder. So a right time to do a stop bank screening can be patients who are having this unaccountable cough. I would want to move on to Dr. P. Arjun, our recently elevated CCI President, Dr. Ashish Dubey, has requested a answer from you. How long we can continue antihistaminics, especially levocetirizine, and any side effect on long-term use? And other than that, kindly tell us some regarding some home remedies when you don't want to use cough syrup.
Thanks for the question, Atri. And actually, there is no real clear-cut guideline which says how long you can give antihistamines for patients. Usually, the only condition where long-term antihistamines are given are for patients having urticaria. For cough, I don't think there is a need to give long-term, other than, as Dr. Sachet said, for upper airway cough syndrome or post-nasal drip, perhaps you may have to give for 2 or 3 weeks. Beyond that, there is no question in continuing antihistamines. And of course, we know that all the oral drugs are associated with side effects like sedation, attention deficit, and other things that are associated with usually the sedative group of antihistamines. So that is part one of the question. The second part, as you said, are the home remedies. There are a lot of home remedies which have been tried in our country for years, and they all seem to work quite well. Perhaps the one that has been used most commonly is honey. Honey, basically what it does is reduces irritation, pain, and inflammation. We can either give honey alone or mix it with tea or lukewarm water and take it. But as Dr. Vibhu has very clearly said, always be cautious, should never give honey to a child less than 1 year of age because of the infantile botulism that it can produce. Apart from that, honey seems to be a very good drug that works. Salt water or saline gargle is another thing which helps, because what basically does is the salt content of that reduces the inflammation in the airways. It sucks out the water and reduces the inflammation, and it also can reduce cough to a great extent. Taking steam inhalation is another thing which has been shown to reduce cough. And the other thing which commonly is used in our country is ginger. Ginger basically also has some effect, basically relaxes the airway smooth muscle. And it has been found that the active content of ginger, which is called gingerol, has an effect of reducing airway hyperresponsiveness as well. Apart from all this, things like peppermint, using peppermint, basically it contains menthol, which basically soothes peripheral nerve endings and actually reduces reduces the threshold for cough. So it reduces cough. And finally, certain small plants like thyme, which is something the mint family. The leaves of it can be used, put in tea or taken, boiled in water and taken. And all these are the basic common home remedies which have been shown to be quite effective in reducing cough.
Thank you, Dr. Arjun. Dr. Manimaran once mentioned that all of his MBBS friends are surgeons and he is the only physician now. So all of his surgeon friends regularly ask him or refer him patient to control cough before or after surgery. Kindly guide us regarding cough syrup with respect to controlling cough before or after surgery.
Yeah, usually electively they won't be asking anything unless they have patients have complaints like cough or allergic history. The usual referrals will be from ophthalmic surgeons before any eye surgeries, or maybe a hernia surgeons before surgery. Usually, you'll be asking routine allergic history. For them, usually anti-allergic or antihistaminic cough syrup is more than enough to control their cough. But many people will be having, when coming to the hospital atmosphere with the air condition, immediately they can have a cough or bronchospasm. For those people, we need to give a cough syrup which contains antihistamine and both bronchodilator agents. And immediate post-op, usually, especially for major abdominal surgeries or cardiothoracic surgeries, they need mucolytics or expectorants usually, because it's essential to prevent atelectasis and further pneumonias. So, and immediate post-op, usually anesthetists use post-intubation cough or post-mechanical ventilation. Usually they will give the local lidocaine or lidocaine in a topical preparation. So these are the agents usually used for immediate post-op or before surgery.
Thank you, Dr. Manimaran. Our country is currently very much active against the war against tuberculosis, and many of our CCI life members are also very active against tuberculosis. Their names are there in the Hall and Wall of Fame. Dr. Sachet, could you tell us regarding cough syrup in patient of tuberculosis?
So cough in tuberculosis has two aspects. First of all, it is not only a primary symptom of TB, it is also a mechanism of transmission of TB into our society. So what Mycobacterium tuberculosis does is it secretes a glycolipid which is known as SL1 or the sulfolipid 1. This glycolipid irritates the nociceptive receptors, and once these receptors are irritated, patient coughs. So there is a school of thought that to control the transmission of TB, we must give cough suppressants, and but the data is not adequate to prove its efficacy. Some people do prescribe cough suppressants in tuberculosis, and also in case of any active hemoptysis during the TB infection, cough suppressants are very helpful. So for transmission control, the efficacy is doubtful. But in fact, if you use respiratory hygiene measures and masks, if patient applies mask, those aspects are more helpful in transmission control of TB. Whereas if the patient is complaining of very thick sputum and there is difficulty to clear out the sputum, mucolytics can be given in TB.
So basically, we understand that in tuberculosis, sometimes cough syrup can be a double-edged sword. We need it to prevent transmission, but sometimes suppression can actually damage the patient.
Yes,
over to Dr. Vibhu. We have an audience question. Dr. Anand P from Tiruvannamalai, Tamil Nadu has asked you, can phenylephrine containing syrup be given in children less than 5 years? And when you are answering this question, please also tell us regarding this most common antihistamine in youngest age for cetirizine or levocetirizine.
So I'll take up both the questions together. So the first is about the phenylephrine. As far as legally speaking, you're not supposed to give it below 6 years of age in India. So that's very clear. The DGCI is not approved it below 6 years of age. Although Despite this, you'll find that it's being given left, right, center, not only in the private sector, also in the public sector. So I mean, it's there in the rule book, but it's not being followed. That's the first part. The second part is about your cetirizine thing. So the levocetirizine has been now approved from 6 months onwards. So below 6 months, you are not supposed to give it, but 6 months onward, you can give it at a dose of 0.25 milligram per kg body weight. So that's has been approved above 6 months of age. Initially, it was approved for above 2 years of age in India. So that's the other two questions which are there.
Thank you for the very to the point answer. And since now we would want to take more and more of audience question, I would request all our panelists to please follow Dr. Vibhu's example and play 2020. We had our Sachin Tendulkar nearing the century, but now we need to play 2020. This question has been asked by multiple people. Dr. D. Mallikarjuna, Bhimavaram, Andhra Pradesh, Dr. D. Arora, Noida, Dr. Sriram Jahangirdar from Nanded, Maharashtra. And this question goes to Dr. A.K. Srivastava, sir. Please tell us a little bit about cough syrup and antihistamine safe in pregnant women and lactating mothers.
So basically, even if even a simple linctus containing glycerol with flavoring agents such as honey and lemon is safe and effective treatment for cough in pregnant ladies and lactating women, also in children. Better Dr. Vibhu sir can put light on it.
So I'll take up this question. I think I can take up this question. So because I do get pregnant females and the young breastfeeding mothers. So I'll just quickly answer the question. So as per the guidelines which is there, the American guidelines, they approve tripolidine and pseudoephedrine, although it crosses the barrier, the breast barrier, and it can be there in the milk also, but it has been approved for the breastfeeding mothers. That's the first part of it. The second thing is even a short-term course of codeine can be given to the mother during the breastfeeding. That's the first part, as far as the breastfeeding part is concerned. Coming to the pregnancy part, it should ideally not be given in the first 12 weeks, no matter what, as sir said. You have so many options. Like for the kids, you have the same. You have options for the mothers. Do you give steam? You give saline. You have nebulizations. You can give humidifiers. You have n number of things. You can because see, first 12 weeks is something which is a very, very crucial moment, and I think you should avoid and prevent any cough syrup whatsoever during the first 12 weeks of pregnancy.
I will just like to continue this answering. The other drugs like dextromethorphan is the drug of choice as an antitussive, and whereas the guaifenesin is the drug of choice as expectorant, which is considered as safe in pregnant ladies and lactating women. And we can also use benzocaine cough drops or lozenges with or without mint or menthol. This may be also used. The antihistamines which are safe in pregnancy and lactation are cetirizine, chlorpheniramine, and diphenhydramine. And but cetirizine is the safest drug, if I am not wrong. And some home remedies, home or natural remedies, as very well said by Dr. P. Arjun sir, like syrup or soup of ossimum leaves, ginger, honey, mint leaves, or Indian gooseberry, licorice, or clove oil may also be used in these ladies.
Thank you. And now we will move on to Dr. P. Arjun sir. Dr. N.H. Krishna sir had a situation at home today. His children wanted him to take them for a movie, a very famous movie, but Dr. Krishna refused that Thursday is my CCI Children's Day, so I would want to watch this very important movie on cough syrup. So Krishna sir is requesting Dr. Arjun to please tell us that antihistamine plus ambroxol combination can actually be something very much unethical, because antihistaminic will dry the secretion and ambroxol tries to liquefy. Kindly comment on the same. This is number one. Secondly, Dr. Arjun, you will also tell us regarding cough syrup management in a extubated or post-extubated patient.
Thanks,
Before he answers, before sir you answer, it just reminded me of that famous dialogue. He was talking of the movie कि इसको लिक्विड ऑक्सीजन में डाल दो, लिक्विड इसको जीने नहीं देगा, ऑक्सीजन इसको मरने नहीं देगा. So now you can go ahead, sir.
Thank you. As Dr. Krishna has rightly said, this is a totally unscientific combination. Now you have an antihistamine which will drive secretions, and then you add something like mucolytic, which sort of increases the secretion. So they act in a totally opposite direction. So we should actually be avoiding such sort of combinations which are working in the opposite directions. That is part one. Number two, cough in management of cough in an extubated patient. Basically, patients who have been invasively ventilated and extubated do not really require cough syrups at all for any reason. Some people may develop an irritant cough after extubation. This is even seen in patients who undergo general surgery with intubation and GA. And after that, because of the intubation, they may have some irritation in the throat, which can cause irritation and inflammation in the upper airway, which can cause a cough. In such rare cases, usually for majority of cases not needed, but in such rare cases, you may have to resort to give a cough suppressant, something which will soothe the upper airway and reduce the cough. Otherwise, routinely, there is no indication to give cough syrup for a patient who has been recently extubated.
Okay, thank you. Dr. Manimaran, sir. Cough syrup combinations that were useful in COVID and for future viral pneumonias.
Yeah, the past 2.5 years we are still managing all COVID patients and now we do ordinary flu sort of presentation. It was initially very difficult to manage, especially first and second waves. Most of the patients had a very dry, irritating cough. Does not control any cough syrup or any preparations. And usually they won't produce much of mucus or phlegm from the airways. Usually it was persisting up to 3 weeks. We tried everything from cough lozenges, the medicines, and cough suppressants, everything. But especially the cough lozenges work very well, especially those which contains dextromethorphan. Usually it's a central cough depression, but usually mild side effects like sleepiness and dizziness. And usually it should be it should not allow it to dissolve slowly. It should not chew or swallow because it has a local numbing effect. And according to history, those who have allergic history or asthma history, they used to have an exacerbation of the wheezing or the bronchospasm. For those people, you have to give bronchodilator and mucolytics. And those with the history of sinusitis, especially the decongestants, helped. And the present wave, now what we are getting is a typical 2 days history of fever followed by a continuous cough at least for a week. All these patients can be well managed with antidepressives. And one more controversial point, the wave 2, many patients responded well with the antifibrotic agents. Those people never had any improvement with the cough suppressants. When we starting with antifibrotic agents, the cough was very minimal and they symptomatically improved very well.
Thank you, Dr. Manimaran. Dr. Arjun, sir. Cough syrup management in pleurisy or pleural effusion related cough.
Usually, cough syrups are not at all required in management of pleurisy or pleural effusion. That is number one. Especially if the patient has pleurisy, the most important complaint and the symptom that they have is the chest pain. So basically what we need to do is to address the chest pain by giving NSAIDs or something to reduce the pain. And in case if you feel that it is bacterial cause, you can give a course of antibiotics for that. If it is viral, it will be usually self-limiting. It's only less than 1% of patients who may have an intractable cough associated with effusion. So in those small subgroup of patients, perhaps you may have to give a cough suppressant. But other than that, largely in pleurisy and pleural effusion, cough syrups do not have any role.
Wonderful. Dr. Vibhu, sir, audience question for you. Dr. N. Prasanna Kumar from Ernakulam. Can long-term use of Montekulast cause any psychiatric illness? And another question, would you want to give codeine in children?
Okay, so the first question, I think it's theoretically yes, it can cause psychiatric issues in children or in adults too. Practically speaking, I have never encountered and I've never heard any of my pediatrician friends talking about any psychiatric issues occurring with the Montekulast. So above 2 years of age, we are safely giving it, and for a long term, we are giving it, and we have not really faced any issues. That's the first answer to the first question. The second question is about the codeine part. Then probably yes, we are not supposed to use codeine at all. It is legally and ethically, as well as medically, it is unsafe, and you should not use codeine below the age of 12 years of age. It's very clear. You're not supposed to use it. It can cause massive respiratory suppression, and you may lose a child. So that's about it. I mean, you're not supposed to use means you're not supposed to use.
Thank you. Next question to Dr. A.K. Srivastav, sir. It's an audience question. Dr. Manikant Gupta from Agra is asking regarding cough suppression to pediatric patient having pneumonia or pneumonitis. What's your take? And what do you understand by excipients in different cough syrup and what are their role?
I will take the first question first. I don't think there is a need of cough suppressant in a case of pneumonia, because in pneumonia the exudates needs to be expectorate out. So I will advocate rather use of expectorant or mucolytics in case of pneumonia rather than using an antitussive. So, but in later stages of later stages of the healing of the disease, we can use cough suppressants. But usually, we should advocate the use of this expectorant or mucolytics in a case of pneumonia. And the another question, a very good question, as per a pharmacologist I have got. So, what is an excipient? So I'm going to define an excipient. It is defined as a medicine other than the active ingredient, which act as a stable vehicle for delivery of the medicine. So in most of the medicines, excipients play a supportive role in delivery. But in the case of cough syrups, excipients have more important and complex roles. Like they can also be the main active ingredients. For example, menthol, glycerol, or sugars have been identified or declared as the active ingredients recently. In a study which explored the United Kingdom electronic medical compendium, can you believe it, over 100 types of excipients were found in 60 different liquid formulations of over-the-counter cough medicines. So there are very numerous of excipients which are used in cough syrups. The excipients used in cough medicines are generally recognized as safe as per FDA and are often derived from food products. And they can be formulated into safe medicines that are popular with consumers, and they provide real relief from cough. Even if the major benefit is demulcent or placebo effect. They also increase the adherence or compliance of the patient by increasing or enhancing the taste or appearance of the cough syrup. So excipients, if I explain it, the excipients are divided into functional groups, various functional groups like sweeteners, thickeners, flavors, colors, antimicrobials, and buffers. Some of the examples I would like to give is in sweeteners, we use sucrose or saccharin sodium or sorbitol, xylitol, or sucralose. These are the sweeteners generally used in the cough syrups. The thickeners.
Thank you, Dr. Abhishek. Yeah, that was a wonderful answer. And I just now got the news that this current webinar has over 900 live logins. So I would want to thank all the panelists here, Team CCI, Team Cipla, that even after the country is in unlockdown, things has opened up, but 900 live people are watching a CCI webinar on a working day, Thursday. Hats off to all of you. Now we move on to the next question. My next question is for Dr. M Manimaran. You have an audience question from Dr. Ravi Kumar Sharma from Bhopal. Could you guide regarding appropriate cough syrup in a cardiac patient with dry cough? And also, can you talk about indication in adult for mucolytic cough syrups? Please unmute yourself, Dr. Manimaran.
Mucolytics. Usually, mucolytics, so usually they'll dissolve because by character change because indicated in bronchitis, bronchiectasis patients, cystic fibrosis patients, and asthmatics, and these are the patients usually will get benefit with mucolytics. There are plenty of mucolytic agents are available, like bromhexin and N-acetylcysteine, carbocysteine. These are the agents usually we give in a combination form. Really, it works well. Along with they have a bronchospasm, then adding levosalbutamol or terbutaline combinations will work very well for the excessive mucolytic function. And coming to the cough suppressant in cardiac patients, usually we should avoid the anticholinergic agents because of it can lead to tachycardia, those things. Better to avoid those lead to tachycardia, those things. And also the preparation with the salbutamol preparation, better to avoid in cardiac patients.
Wonderful, thank you. Over to Dr. Sachet. When we are talking about mucolytic, kindly guide us regarding some adverse effect or notable drug interaction of mucolytic preparation. And second, you have an audience question from Trivandrum, Dr. Srivastav, who is asking you about post-cough COVID cough is becoming common in our society, and what may be the perfect medication to get it corrected? Dr. Sachet.
So, fortunately, the expectorants do not commonly exhibit adverse effects, and but some of the patients do report gastric upsets with mucolytic drugs, and because these mucolytic drugs irritate the gastric mucosa and can cause bloating, diarrhea, and because of their salt action, that is the secretion enhancer action, they can cause rhinorrhea, lacrimation. Some of the patients have also reported dizziness, skin rash, and headache. And there used to be a secretion enhancer by the name of potassium iodide. Since it is an iodide, there is an iodide component in that. So it used to affect the thyroid function, and also the potassium component used to cause irregular heartbeats. But now the use of potassium iodide has been stopped. The ammonium salts like ammonium chloride, they cause nausea, and also it increases the secretions with its reflex action. So these are the common side effects that can be seen with mucolytic drugs. Now coming to the interactions, the N-acetylcysteine, which is being commonly used nowadays, it should not be given with activated charcoal. The activated charcoal preparations absorb 90 to 95% of the N-acetylcysteine. But N-acetylcysteine has also shown some protective effect from the toxicity of IV cyclophosphamide, and also especially the urinary tract toxicity of cyclophosphamide. Also, in some animal experiments, it has been shown to protect against the cardiomyopathy caused by the doxorubicin. So in these two chemotherapeutic drugs, N-acetylcysteine can actually help. Also, the Dornase alpha, which is a relatively newer compound, can be added to tobramycin in Pseudomonas infection, and also in Staphylococcus aureus infection. And some compounds such as carbocysteine, erdocysteine are combined with amoxicillin or ampicillin in case of chronic bronchitis. So these are the common interactions and side effects of the mucolytics. And also coming to the, can you repeat that question?
Yeah. Basically, they are asking about Dr. Srisan from Trivandrum. Post-COVID cough is becoming common in our society, and what may be the medication to get it corrected for post-COVID cough?
Yes. So COVID being a viral illness, we know that post-viral coughs actually do not require any cough syrup. These are basically the epithelial damage caused by the viruses in the uh, respiratory tract, which is causing the vagal afferents. So some pharyngeal demulcents like honey or licorice, etc., can help. And otherwise, there are no specific cough syrups for post-COVID cough.
That's a very bold point, and I would want to reinforce this point that post-COVID cough may not require cough syrup. Still, if indicated, go for soothing agent or pharyngeal demulcent. I would want to move on to Dr. Manimaran, sir.
Hi,
Please
Atri.
talk about, yeah, please. Dr. Krishna, sir, what a pleasant surprise. Please, we are very privileged that Dr. Krishna is with us. Please, sir.
No, thank you so much. Vibhu was repeatedly calling me in the chat box. That made me to arrive here. And I'm extremely happy to see that it's going great. Atri, you are doing a wonderful moderation as always. And I was more involved in this webinar personally because this conceptualization of the topic was exclusively mine. I thought that this corner isn't touched by many of them in India in webinars, and this is going great. And thank you so much for coming here, Vibhu, Sachet, Arjun, Manimaran, and Dr. Abhishek Kumar. I would request you all, Abhishek Kumar, I was extremely happy that you came out with a chart earlier. Can that chart be made visualized here so that people can take a screenshot or can keep it for their references, and even in YouTube channel, this will be stored forever. And while going ahead, when you have still few other minutes left, you could probably go an attempt of indicating, classifying the coughs the way you classify the cough syrups. So classification of coughs, not only dry and productive. Just now, as it was, they were quoting regarding the post-COVID cough, for that matter, and anything else you would like to do, you do it. And I just jumped in here as the movie director, as a guest appearance like Subhash Ghai does in his movies. So that's it. You're all doing great job. Thank you so much. Thanks for making CCA proud always. Atri, wonderful to see that CCA logo behind you.
Yeah. So thank you, sir.
Bye-bye, everyone. Bye-bye, everyone. Thank you so much, everyone here. Thank you. Bye-bye.
Bye, Krishna.
Bye.
We have a question for Dr. Manimaran. Dr. Gopi Krishna from Vijayawada, Andhra Pradesh. Please talk about some rationale of combination cough syrup which are now banned in India. And at the same time, please tell us a little bit about cough syrup management in pulmonary fibrosis and other ILDs.
Yeah. Coming to second question first, the pulmonary fibrosis is a very challenging one, especially since the cough is a frustrating, nagging one. Since it has multifactorial cause like biochemical, mechanical, and neurosensory involvement, very difficult to manage cough, especially in interstitial lung disease like pulmonary fibrosis. Especially it's a palliative cough suppression only. You have to mainly relieve the symptom. Okay, so there is no licensed or approved cough regime in case of interstitial pulmonary fibrosis. Many people usually we used to give sip of water at regular intervals throughout the day, honey and menthol-based lozenges. All these things will relieve temporarily. We can have a good relief. And not only should treat that, and also we should manage with the proton pump inhibitors and GA motility agents also. Combining steroids with the antifibrotic agents along with these cough syrups, definitely they can make their life better without much of cough. The first question again, sorry.
First question was, please talk a little about certain coughs, the rationale for certain combination being banned in India in cough syrup.
Yeah, these all codeine agents which contains all narcotic agents is totally banned in India, even though it was very useful in suppressing the cough because of a lot of side effects and addictiveness. It has been banned, and mostly it should not be used those with the medications on especially epileptics or those who have antidepressant medications. Those things should be avoided. That's why it has been banned because of addictiveness.
Okay, thank you. Over to Dr. Vibhu. When you are asked to choose, name your popular 3 cough syrup combinations and why do you use them? And also an audience question for you, Dr. Asim Mehta from Maharashtra. Please tell a little about certain new drugs like levocloparastin and levodropropizine. Dr. Vibhu, sir.
Okay, so as far as the cough syrups are concerned, you get the standard combinations which are there, the chlorpheniramine, phenylephrine with paracetamol. That is the various brands are available. In some of them, there is menthol, and there are cough syrups which are there with noscapine and ammonium chloride also. So you have different cough syrups which are there. But as I told you, the purpose as far as the pediatrics is concerned, the cough syrup purpose is just to get over with the alleviating the symptoms and just making the child a bit more relaxed, sleepy, and kind of slowed down. So I think most of the time with the chlorpheniramine, phenylephrine with paracetamol works well for us in most of the cases, and I've been using that in most of my patients like other pediatricians. So I'm no different. So although I would be very, very clear that as far as the children are concerned below 6 years of age, we should just give the supportive care, which I always prefer. So there's going to be steaming, a lot of saline sprays which I use, and these are the 2 things which are the mainstay of the treatment. So I always tell the parent that, look, the medicines are going to work, but the role of medicines is just about 20 to 25%. The rest, about 80%, is your efforts. So आप मेहनत करेंगे तो आपका बच्चा ठीक होगा. That's the first part. As far as the levocloparastin is concerned, above 2 years of age, it has a good effect, and it is safe also to be used above 2 years of age as a cough suppressant. So as far as the children are concerned, and where you have the post nasal drip as well as the pharyngitis which is there, and tonsillitis which is quite common in case of children, the newer drugs actually work very well for suppressing the cough, because you need time for your steaming, for your saline, and for your supportive care to work. So during that period of time, you can use it. Again, it's like alleviate the symptoms of the child, and the parents will be happy. Otherwise, they'll change the pediatrician.
Yeah. I had an audience.
One more thing is there, a lot of prescriptions which I see, not of pediatricians, but of general physicians who are treating pediatric patients. So what they do is they give a cocktail of cough syrup to suppress the cough and all, and then they'll give a bronchodilator too. I think the use of bronchodilator has been overtly overusage has been there, especially the levosalbutamol oral suspensions which are there. So they also come in the cocktails. They don't come as single ones nowadays. So they also come as cocktail, and you'll find 2 syrups are there. One is a bronchodilator, one is a cough suppressant, and everything. So it's like कैसे तो किसी ना किसी तरीके से तो खांसी ठीक हो जाएगी. But I think that's not the right way to do, and especially in case of children, if you're using a bronchodilator, just remember one thing. One of the major side effects which I've seen, especially in the young children, is that there's an excessive cry which can be there. So that is something which you have to be very, very aware, because the child can become even more irritable when you're using a bronchodilator. So the child is going to be sleepy and irritable, just remember. So that's going to create more troubles for you rather than making your life simpler.
Wonderful. When you were just concluding, one sentence struck my mind, that when you are talking about cocktail, I suddenly realized that cocktail is basically a mixture of liquids that contains alcohol. So basically, when we are discussing cough syrups, we are basically talking about the most readily available cocktail therapies or cocktails in the world, rather than looking for such expensive cocktails served in the bar. We actually
So
have cocktails in our cough syrups.
cough syrups, that's right. And I would say that, look, apart from everything which I've seen and I've experienced, and even for my children, if you talk to your parents or probably your grandparents, they'll tell you the role of brandy to be given during the winter season to the children. They just give about 5 ml of it, and it works well. So it did happen, with my children too. They were not responding to any of the cough syrups at that time, and I had not even read about them, in such a detail and all. So even I was like, the what to do. I was doing nebulizations, I was doing steaming. So I just gave them brandy, and it works wonders in a day. You don't need more than 24 hours for the child to, it works wonders for everybody,
Thank
probably
you.
for you.
Thank you. We have a comment here. I am just reading it out, but we can't answer it because it's not in the topic. Dr. Uma Maheshwari from Tamil Nadu has asked about nasal spray dosage. But since our topic is cough syrup, we shall not take this question now. We have a question from our president, Dr. Ashish Dubey from Bhopal. I would request Dr. A.K. Srivastav, sir. Dr. Ashish Dubey from Bhopal is asking management of psychogenic cough. And also at the same time, you please tell us that certain cough syrup molecules are available as tablets. Then why do we go for syrup when these are also available as tablets?
First, I would take that first question. So the treatment for psychogenic cough. For psychogenic, anything psychogenic, we need psychotherapy or antipsychotic. The role of antipsychotics and antidepressants are there in the psychogenic cough, because any of the antitussives or expectorant is not going to work there. But if we talk about levocloperastins or some centrally acting cough suppressants may also act in psychogenic cough. But counseling a patient and giving him appropriate antipsychotic medicines or antidepressant would help in alleviating the psychogenic cough. And coming on to the second question, a very good question. Because most medicines are bitter powders that are formulated as tablets and capsules, but cough medicines are an exception, where taste and appearance of the medicine are more important to the patient. It gives more satisfaction than the pharmacology of the active ingredients. And so the cough medicines are unique in the form of a viscous sweet syrup. The active ingredients like dextromethorphan or guaifenesin could readily be given as tablet or capsules without any loss of pharmacological activity. But because of the history of cough medicines being formulated from food substances like honey and then later on as sweet viscous syrup, this formulation is still expected by the patient consumers. And the fact that the viscous sweet formulation has persisted for hundreds of years indicates that this formulation is providing some benefits to the patients with acute cough, maybe psychologically or demulcent effect, and that the advent of the pharmacologically active agents such as dextromethorphan and so on meant that these drugs were simply added to the sweet syrup formulation, which had already proved to be of benefit to the patient. But I would never advocate the use of in the form of cough syrup, the medicines, for a long term. We can switch to various other forms like inhalers, like in other cough conditions. Thank you.
Thank you, Dr. Abhishek. We had a question, Dr. Sheila.
When I
Yeah, Dr.
mentioned about
Vibhu,
the
please.
alcohol, when I mentioned about the alcohol, even in the adults working, it's basically what happens with the cough syrups, because I just wanted to continue with what Dr. Abhishek just said. The cough syrup gives you a kind of a psychological feeling, and if you add alcohol to it, it further elevates your mood and gives you a relaxing kind of a thing. So you forget about your cough and you forget about your tensions and you're kind of a relax. So the doctor becomes really a good doctor. Means you help
Okay.
out the patient to relax.
Yeah. We had a question, Dr. Sheila Malani, Bhopal, which we have already answered. Cough persisting after COVID. After that, we have another comment from Dr. Krishna, sir, that when we were talking regarding to Montekulast, and something regarding psychiatric. Dr. Krishna sir says that his son is getting Montekulast greater than 5 years, but he is seeing him becoming sharper and intelligent day by day. So please note this. Then we have a question from Dr. Manju Soneja from Bangalore. Dr. Sachet, for you, dry irritating cough lasting for quite some time after a viral illness. And secondly, when Dr. Abhishek was mentioning about acute presentation, how would you want to give or where would you want to give cough syrup in acute presentations?
So as I've already mentioned, the etiology of the post-viral cough is epithelial damage, and it is self-limiting. Usually it self-limits itself in about 3 to 4 weeks, and we do not require cough syrup specific for this post-viral cough. We can give pharyngeal demulcents for the same. And as far as acute onset cough is considered, first of all, we have to decipher what is causing the acute onset cough. If it is a URTI, upper respiratory tract or lower respiratory tract infection, we require appropriate antibiotics. And for any asthmatic cough, we require the bronchodilators and inhaled corticosteroids. Hemoptysis is one condition where you actually require immediate cough suppression. And for this, suppressants like codeine and dextromethorphan are quite popular. And also in the post-nasal drip or the upper airway cough syndrome, you can give decongestants and antihistaminics. And any acute onset cough, that is a cough which has originated for less than 3 weeks of duration, we should first of all rule out any life-threatening conditions such as severe pneumonia, pulmonary embolism, and congestive heart failure or pulmonary edema, because those conditions then again require further intensive care and therapy.
Thank you. Moving on to Dr. Arjun sir, Dr. M. Sangeetha from Chennai is asking about post-nasal drip cough management, and please talk about a chronic neurology patient with chest symptoms with respect to cough syrup management.
Thanks. I'll take the first question first. That is post-nasal drip management of cough. We know that one of the most common causes for a chronic dry cough in a patient with a normal chest X-ray is post-nasal drip. The other causes being gastroesophageal reflux disease and cough variant asthma. In post-nasal drip, basically what happens is there is dripping of secretions from the sinus to through the posterior pharyngeal wall. So the most important thing in the treatment of post-nasal drip are the use of antihistamines. Usually the first or second generation antihistamines have been shown to be more effective than the newer non-sedating antihistamines as far as treatment of post-nasal drip is concerned. If chronic rhinosinusitis is the reason for post-nasal drip, perhaps the use of an inhaled nasal steroid may also help reducing the symptoms. So that is the first part. The second part is in a patient having chronic neurological problems and cough. The most important thing one should understand in this particular context is that you should not use a cough suppressant to suppress the cough. The basic problem is these patients have a weakened cough reflex and they are more prone to aspirate. So the most important thing is if the patient has the secretion management is the most important point that one should understand here. If the patient has thick mucus secretion, the use of a mucolytic agent may help. Other than that, other measures like cough assistance devices, chest physiotherapy, and all the other things are more important than the use of cough syrups. And of course, if the patient has some tendency to aspirate, the most important thing is to use PPIs as a prophylactic agent to prevent aspiration. So these are the things that one should keep in mind. Avoid cough suppressants, mucolytics if needed, and prevention of aspiration.
Thank you, Dr. Arjun sir. Very crystal clear. Dr. Abhishek Srivastav, Dr. Sachet Dawar, a smoker's cough or patient of COPD with cough, your guidance with respect to the same. Dr. Sachet.
Yeah, so we must realize that cough is a protective reflex. Basically, coughing is there to expel the chemicals that are going inside with the smoking. So the thing is that patients of COPD usually have wet productive cough. That means a lot of secretions are there. Also, the ciliary action has been reduced. The mucociliary action is reduced in these patients. So first thing that you should advise a COPD patient with a smoker's cough is to quit smoking. The patient should quit smoking immediately and you should have adequate hydration. Water intake should be very much adequate. Also, home remedies such as green tea, honey, and vitamin C, etc., can help. And then we can advise mucolytics if the patient is having difficulty to expectorate. Also, we must keep in mind that COPD with obstructive sleep apnea, that is an overlap syndrome, can give rise to increase in carbon dioxide levels in blood. So we should avoid suppressants in patients with COPD and OSA. It can actually be dangerous. It can lead to hypercapnia.
When you mentioned green tea, I remembered a sentence that green tea is so good that you should give it to your nosy neighbor so that they don't come to your home again. And one audience question from Dr. Chandra Joseph, Thanjavur, Tamil Nadu. I would request Dr. A.K. Srivastav sir to please take it. If there is incessant cough, can a small dose of tramadol be given?
Yes, why not? Because tramadol basically an opioid, but it has some less sedative, less antitussive action more than a sedative one. So tramadol basically will act by sedating the nervous system rather than as an antitussive. So we can give, but it is not rational to use tramadol as a cough syrup or antitussive.
I have
Wonderful.
seen in
Dr.
OT
Arjun sir,
actually at
Acha,
times.
Dr. Vibhu, please. Yeah.
Yeah, I've seen in OT, when I'm attending the cesarean sections, at times, the woman, because that is basically under the spinal anesthesia. So at times the female is coughing and the anesthetist gives tramadol. So I've seen that happening. Practically, I'm talking about.
Wonderful. Dr. Arjun sir, cough syrup caution in liver and kidney disease.
Yeah, it's again a very important question. Which are the syrups that you've done with the contents or the chemicals that you should use with caution in patients having liver and kidney disease? Let's just take liver disease first. Of all the cough syrups, perhaps the most important one which one should always keep in mind not to use would be the use of dextromethorphan. Paracetamol and dextromethorphan are two important drugs that should be used with caution in patients having liver disease, and it is advisable not to use dextromethorphan containing cough syrups in patients having advanced liver disease. As far as kidney disease is concerned, the most important one are to, as far as possible, to avoid cough syrups containing decongestants like phenylephrine and pseudoephedrine, because these drugs can actually cause vasoconstriction and worsen kidney disease. And also in patients who have end-stage kidney disease, there might be accumulation of centrally acting cough suppressants, and that will actually add on to toxicity of these drugs. So these are the drugs which need to be used with caution in patients having liver and kidney disease.
Wonderful, wonderful. Dr. Vibhu sir, pediatric patient, many times antibiotics are also given as suspension. So can you talk about certain cough syrup and antibiotic syrup to be avoided together, or how they need to be dosed basically?
Per se, I was reading about the cough syrup, so I didn't really come across, the cough syrup and antibiotic, which cannot be given together. But what I've seen is the macrolides, if you use with the cough syrup, they have a synergistic effect, and macrolides work very well as anti-inflammatory. Rather, when I was in Patel chest, I remember the roxithromycin in the adults being used for allergic rhinitis for 4 to 6 weeks, because it has an anti-inflammatory effect. And the same in case of the children, we normally don't use roxithromycin commonly in children because of the acidity issues. So we use clarithromycin or azithromycin, and I think synergistically it works well for the inflammatory part. But as such, there is no contraindication for antibiotic versus the cough syrups which I have come across.
Wonderful. Very quickly, Manimaran sir, please talk about cough syrup precautions in geriatric medicine. Please unmute yourself, sir. You are muted.
Good question. Since they already have age-related comorbidities and also they will be on multiple drugs, drug interactions are the important concern, also the side effects. Better to avoid combination cough syrup, especially for geriatric people, because they need only the necessary medications. Also, better to avoid anti-tussive agents which produces sedative effect and the drowsiness, because the history of fall is very common with this geriatric population with the anti-tussive agents. And also, decongestants also should be avoided because many decongestant agents has urinary retention. Most of them will be having brain prostatic hypertrophy. Also, they will be having glaucoma. So decongestants has to be avoided, and just give specific cough syrup. That's an important thing. And also, amount of cough syrup is important. Many people they will take overdose, so that should be avoided. And the safe agents are mucolytics and expectorants, and antihistamine cough syrups are safe according to their symptoms.
Thank you. We have touched every comment and every question asked by the audience before time. That's something very good, because it's the audience demand that makes us do this webinar every week, separate topic, interesting, unique, no repetition. So we covered all the audience question. All of you here who are listening to us, if you want to be a part of a CCI webinar, first thing first, please become a CCI Life member. Secondly, if you are a CCI Life member and yet you have not got chance in a webinar, I would request you to please personally reach out to myself, Atri Gangopadhyay, or our current CCI President, Dr. Ashish Dubey, CCI Secretary, Dr. Anil Maske, CCI Webinar Coordinator, Dr. Vijay Chennamchetty, or any of the members, Dr. Krishna sir, Dr. Narayana sir, Dr. Ravi Dosi sir, Dr. Kirat madam, please reach us to us. We shall ensure that you are part of a CCI webinar. If your spouse is a doctor, but from some other field other than pulmonary medicine, we can still accommodate them in a CCI webinar, because in this webinar, you can see we have someone who is a pharmacologist, we have someone who is a pediatrician. So we always try to decide a CCI webinar. We always try to design the CCI webinar with one or two people from other specialties. So please reach us to us. If your spouse wants to be part of a CCI webinar, but is not a pulmonologist, we have option for that also. Now, before concluding, I would quickly request our eminent panelists over here, one by one, to please give 2 or 3 sentences as the take-home message. Dr. Manimaran sir from Chennai first.
Yeah, no, instead of giving cough syrup, that's okay. Always ask them to cover their cough. That's my take-home point.
Thank you, Dr. Manimaran. Very crisp. Dr. A.K. Srivastav sir, please.
A cough syrup, an ideal cough syrup should be a rational fixed dose drug combination with almost similar pharmacokinetics. It should be highly effective and acceptable and least adverse effect. The preparation should pass the pharmacovigilance as well as the prescription auditing from a pharmacology point of view, I am saying. And the last point I would like to make, for acute cough, yes, syrup will do, but for chronic cough conditions, it is better to switch to other therapies like inhalers or some tablets. Thank you.
Wonderful. To make it simple, what A.K. Srivastav sir told is basically the best cough syrup is our cocktail, which is sold at the wrong places. They should be sold at the pharmacies instead. I would request Dr. Sachet, your concluding remarks, please.
I would like to conclude by saying that your prescription is not to please, it is to treat. So first of all, diagnose properly. And if at all cough syrup is required, now I think after seeing this webinar, you can take a conscious decision on which cough syrup is the best suited for your patient.
Dr. Vibhu sir, legal expert, pediatrician, pulmonologist.
Okay, so first thing is talking of the legal aspect. So you're not supposed to give cough syrups to any child who is less than 6 years of age. That's legally there. Apart from a few of the syrups which you can use, like the cetirizine, the levocetirizine, or the levocloperazine, which has been approved above 2 years of age. That's the first part of it. Below 2 years of age, you're not supposed to give. The second most important thing is that even if you're using, no matter what, you have to be very clear. In the child, the supportive therapy is the one which works the best. That's going to be the normal water steaming with the the saline sprays. That works best for us. So these are the two things which are very important. And lastly, the alcohol, as Dr. Krishna said, that he just messaged me and he said that lakh rogon ki ek dawa hai, kyun ghabraye. So the alcohol works best for all age groups. So and that's my personal experience too, that brandy works. So at the end of the day, see what happens is when you have cough, you're out of your mind, you're crazy, and you want some relaxation. So probably alcohol works, and in children too, the brandy works well. So that's the end of it. But that's unofficial. Officially speaking, just give supportive care and it works best.
Dr. Arjun, sir, please unmute yourself. Your take-home message.
CR3, as we all know, patients presenting with cough pose the most important challenge to any practicing pulmonologist. If it is a real challenge to identify the reason why the cough is present. So and from my experience with a proper clinical examination for a detailed history, in 99.9% of cases, you will be able to find out the reason why the cough is. And it is important that you tailor your treatment according to the cause. And that is the only thing which is going to give relief to the patient. So as you have seen over this last 1.5 hours, cough syrups may not work in most cases. There are many other treatments that you might have to offer. But the most important thing is to identify the reason, the cause for the cough, and treat it appropriately.
I just received a message for Dr. Krishna, sir. His take-home message. Cough syrup is like a pickle to the main meal and should not be considered the main meal itself. So please remember this. Before we conclude, I would again want to say, we would love to hear you. If you have not been part of a CCI webinar, please tell us. We'll be very happy. At CCI, Dr. Krishna, sir, and we strongly believe that no experience means no job. And no job means no experience. So we shall very happily give you that experience as a speaker at a national platform with over 800 to 900 to 1000 live logins, so that you can always say that, yes, I have experience, and you will definitely get better opportunities. Before concluding, I would want to thank.
So I don't want you to conclude before I share my first time experience. When I was told by Krishna sir to do the first CCI webinar, I think that was about 2.5 years ago. And I was like so tensed, and I was like, I don't know what's going to happen. You're going to have so many people who are going to be watching. So, it ultimately, once you do it once, twice, thrice, today I'm much more relaxed as compared to what I was last year. So probably once you are a part of the CCI, once you are there, and it gives you a lot of confidence, but because once you are addressing a population, once you are addressing, the number of people, about 900, 800 login people, and they're all educated, they're all pulmonologists. So obviously your confidence increases, and that helps you in other seminars and the other CCI, in other CMEs also, which you can do it at your local level. So when you're addressing people of about 30 people or 40 people, you're like, ye to kuch bhi nahi hai. It's just nothing. When I can do it against standing in front of 900 people, then this is a very small audience. So it gives you a lot of confidence.
Yeah. I would want to thank Cipla Respiratory, who help us doing these webinars, Blueberry Events, the technical people, Dr. Krishna sir, Dr. Narayana sir, who are our founders, current President Dr. Ashish Dubey, current Secretary Dr. Anil Maske, our CCI webinar coordinator Dr. Vijay Chennamchetty, and a team of people who select these topics and the panel, Dr. Kirat Kaur Sibia, Dr. Shivani Swami, Dr. Rajadhar sir, Dr. Nitin Abhyankar sir, and all our panelists who did all this preparation, very tough preparation, to ensure that they told you the latest cutting edge things, steer clear of controversy, and give message. So from Chest Council of India, wishing everyone over here a wonderful, happy festivities. Good night to all.
Good night.
Night.
Good night.
Night.
Thank you.
Thank you.
Good night. Thank you.